Good day, and welcome to the TMIT National Research Testbed High Performer webinar series. This is Dr. Chuck Denham welcoming you, and I have the great joy of having a terrific group of speakers and panelists today. So we'll move very quickly through the housekeeping details. For those of you that are watching the slides, I'm on slide 3, and we just want to draw everybody's attention to the lower left-hand corner of your screen. If your audio volume is not high enough, after you advance volume on your computer and you still can't hear it, you can click on the telephone symbol, the icon in the lower left-hand corner, and we can give you a phone line. Slide 4 is, for those of you that are watching the slides, is the landing page for www.safetyleaders.org. And for those of you that have logged on the phone and have not downloaded the slides, you can click on the upcoming events and click the link, and then you will get to the page where Dr. Srinivasan and Dr. Boat's pictures are on the screen, along with the title for today's webinar. And this page is the page you'll come back to watch future videos, be able to download resources, get the transcript of this session, and also continuing education materials. I'm on slide 6 in addressing where you can follow us on Safety Leaders, Twitter, Facebook, etc. And I'll stop on slide 7. Our purpose statement for TMIT is that we'll measure our success by how we protect and enrich the lives of families, patients, and caregivers. And this is especially important now as we consider this issue of Ebola. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. I won't delay very much on slide 8, which is our disclosure statement, but no product, service, or technology will be discussed on this webinar. However, I want to declare this as a full conflict zone. What we have done with our invitations is we've invited suppliers, providers, and purchasers of healthcare who all have conflicted interests regarding the treatment and payment for treatment of services for infections. But we realize it's so critical that all of us work together in this area of healthcare-associated infections highlighted by Ebola. So we're declaring if we won't be answering any questions regarding a product or a service if they come through Q&A, but none will be presented. But we want to make sure that everyone knows that everyone has embedded conflicts, having worked with companies and services in infections. Slide 9 is another disclosure statement which you can follow. And then our speakers and reactors pictures are on slide 10. We have Dr. Arjun Srinivasan, the lead at CDC on helping us understand Ebola, and also has been a wonderful partner of ours over the years with our Green Light program focused on healthcare-associated infections and our summits. Dr. Greg Boats, who's a professor at MD Anderson, a critical care and anesthesiology physician who will be speaking after Dr. Srinivasan. Dr. Darren D'Agostino from Fort Worth, who's chair of internal medicine there at the University of North Texas. Terry Wheat, who's the head of clinical services for Shriners Children's Hospital in Chicago, and also, very importantly, on the board of directors of one of our great safety net hospitals treating the vulnerable and the poor in Chicago, which is the Sinai Health System. We have Frank Guilleteau from our team, our Chief Technology Officer, and Mary Foley, who will open us if she's able to log on. She said was at another meeting, but Mary is the former president of the American Nursing Association, a professor at the University at UCSF in San Francisco, and a great patient safety champion. And Carl, do we have Mary on? And generally we have a patient advocate champion speak to kind of set our inspiration hats on, and I know that we'll give Mary the opportunity when she logs on later to do so. And Mary had a patient safety accident in her own family with her mom, which really gave her great passion for patient safety, and I know she will express the importance of really focusing on patient safety and quality. I'm on slide 12, and in my introduction to Dr. Srinivasan, I'm going to address in a series of very short slides kind of a concept of Ebola being our canary in the mine. in that we really need to take the learnings from Ebola to focus on the 700,000 deaths we have in our acute care hospitals and the 75,000 healthcare-associated infection deaths, the 700,000 that we give infections to, 1 in 25 patients, and the 75,000 deaths that we have from healthcare-associated infections, and really consider this issue of it being our canary in the mine. It was really interesting to kind of study up on this and know that canaries were used for miners because their metabolism is such that they detect carbon monoxide and methane gas much sooner than we do, and the death of a canary not only symbolized that the air was not safe, but also the potential risk for impending explosions. And canaries were used up to 1987. So this canary in the mine, I think, concept and is one we can use with our boards to say, listen, what we learned about Ebola, although the frequency, it's a high impact event but low frequency, but it really is the tip of the iceberg that really expresses what this modern healthcare cover did. There's not one of us in healthcare that didn't have our hearts go out to Texas Health Resources and Presbyterian Hospital and their leadership, in that I don't think any of us, no matter what, would have been prepared for the serious consequences of these kinds of infections, and we still feel unprepared. And I think it's really critical that we focus less on where mistakes were made and much more on what we can learn from them. Now, this is the anonymous polling that we did of you as a group. We have 25,000 people in our test bed in 3,100 hospitals, and we, in our last series of webinars, we asked about the importance of a webinar on Ebola and emerging infection best practices. 63% of you rated it a 10. 9% nines, and this gave us a net promoter score. If you subtract everybody with a 1 through 6, one of the highest net promoter scores this audience has ever given. This is our 75th webinar of giving free continuing education credits for 90-minute courses, and we've rarely ever seen anything this high. The second slide, on slide 16, were, would you like to see innovations in protection of caregivers and patients, including cleaning innovations, used to protect against contagious infections? And you gave us a 71% said that this issue of cleaning and a number of the maybe less spectacular topics are about cleaning and about sanitation and about cleaning up after patients that have infection and these critical issues referable to C. diff and other conditions. And so this is the response from you as an audience. Dr. Srinivasan is going to help us understand how similar Ebola is to neurovirus, and there's a lot we could learn from other industries such as the cruise industry and others that could help us. I'll close by sharing one other element, and everyone invited to this webinar and everyone that attends it will get a link to a video that we'll be providing that will use a series of clips regarding the idea of the concept of our canary in the mine and how Ebola really is a warning that our environment could be much safer for both caregivers and for patients. When we were preparing that video, which you'll be able to link onto and watch, and we'll post it on YouTube and make it available after this webinar, we found a Wall Street Journal video clip of a study that they did where they contacted the FAA and said regarding airplanes, and this made questions regarding airplanes before the Frontier flight, and they said, well, who's cleaning the planes? Who's responsible for potential infections in the planes? And the FAA told them in their video, which you can see, they said, oh, well, that has to be OSHA. They contacted OSHA, and OSHA said, oh, that has to be the FAA. They recontacted the FAA, and they said, well, if it's not OSHA, then it's the FDA. They contacted the FDA, and they said, no, we only deal with food and beverage. So the Ebola crisis, although a limited number of patients, has now really helped us understand much more about our national preparedness for infection. And when we followed the sensationalistic coverage in the press, it further kind of gave us a wake-up call as caregivers that there's much more that we need to focus on than just the acute care event when somebody gets an infection. So the series of press events will also be in this short video. I'll close by saying that we're going to be asking you after Dr. Srinivasan's presentation whether you'd like a 3-webinar series, another free series, to focus on the hazard mapping of where the hazards are. We've done a lot of work on this in prior projects of where are the hazards for infections, where can the processes break down, and where can we learn from things like those things that Dr. Boats will share with us regarding practicing procedures. And basically the close is, our canary in the mine died. It really showed us that there is so much more that we could learn. It wasn't the fault of anyone. We'd never had this event occur before. It allowed us to find out where we can make things safer. And so I'd like to close with that and then ask you to join me with Dr. Srinivasan, who will be speaking. Now, his slides will be a different aspect ratio, and you'll see two different sets of slides that you can that you'll be able to download from him, because his are wider. So you'll have both PDFs of our whole slide set and then his. He's the Associate Director for Healthcare-Associated Infection Prevention Programs in the Division of Healthcare Quality Promotion at CDC's National Center for Emerging and Zoonotic Infectious Diseases. He's also a captain in the U.S. Public Health Service. He's spoken for us numerous times. He's spoken at our national summits that we've done in Washington at the National Press Club, and he has really been so helpful in practical matters regarding infections, and we're so grateful he took time for us today. Arjun?
Thank you so much, Chuck. And thank you all for joining us today. It's really a pleasure to be able to be with you for this presentation. I really want to emphasize that we view this as a partnership between all of us in public health and all of you who are providing healthcare out in the field, in our hospitals and clinics around the country. Our job in public health is to work closely with you so that you have the information and strategies that you need to do your jobs safely and effectively. And we view this as the opening of a dialogue. We do hope that as you have information that is relevant for us, and as you have recommendations for how we can be more helpful, that you will, of course, let us know how we can do that. We have learned from experience taking care of patients with Ebola virus disease in the United States that this is complex and it's challenging. We've also learned that it can be done safely and effectively. And to do that, we have to have very strong quality and safety systems. And in that regard, Ebola is like any other healthcare-associated infection issue where the key is a strong safety system. We think that there are 5 pillars on which that safety system needs to rest. There needs to be leadership from the very highest level to provide the resources and support for effective prevention precautions. You need to have someone on site. If you're working to take care of a patient with Ebola, there needs to be a site manager who oversees those precautions, helps you get ready, helps you manage. You need clear and standardized procedures that are based on the best evidence and current recommendations. You need to practice again and again with whatever personal protective equipment you'll be using. And you need to make sure that there's oversight of those practices, that there's someone designated who's available to watch as healthcare workers provide care, and in particular as they put on and remove protective equipment to make sure that they are being safe. Let me begin by talking a little bit about the current outbreak in Africa, because of course that is the key situation that we must stay focused on. As of earlier this month, there were more than 13,000 cases in West Africa and close to 5,000 confirmed deaths. My understanding is that both of those numbers have risen in the last few days to close to 15,000 cases and over, I believe now, 5,000 confirmed deaths in the countries in West Africa that are most highly affected, which is Guinea, Sierra Leone, and Liberia. Now, you've heard estimates from CDC in the past, but you've also recently heard from our agency director, as recent as yesterday, that the good news is we don't think these worst-case estimates are going to come to fruition. Several months ago, we estimated that without intervention, we could see as many as 1.5 million cases of Ebola in West Africa by the middle of January. And the good news is we now think that that's not going to happen. And that's wonderful news, but I think it's only a need and an emphasis for us to redouble and continue to have a strong work in Africa, aggressive support of the efforts that are going on there to control this epidemic. Not only is this critical to saving thousands, maybe tens of thousands of lives in Africa, but it's also critical because we know that no place in the world is safe from Ebola as long as there's any place in the world where there is an Ebola outbreak. In the United States, there have been a half dozen folks who have been evacuated to the United States to receive medical treatment who were infected in West Africa and have been transferred here. There have been 4 people who have been diagnosed with Ebola in the United States. 2 of those people were, of course, patients who had been in Africa, were exposed there, but were diagnosed in this country. And then the other 2 were, of course, the 2 nurses who cared for one of those patients in this country. We know that there were 2 nurses who contracted Ebola while caring for the first patient who was diagnosed with Ebola in the United States, in Texas. We are so grateful that both of them have made full recoveries and are back leading their lives, and that's wonderful to know. It's also encouraging that as of November 20th, there have been no other healthcare workers who have provided care for a patient with Ebola who have contracted Ebola, and we are certainly enormously grateful for both of those things. CDC has been very active for a very long time, for several months now, working to respond to the Ebola epidemic. A lot of our response, of course, especially initially, was focused on supporting Africa. A lot of our response remains focused on supporting Africa. We have more than 300 staff who are deployed around the globe, many of them in West Africa. Roughly 1,500 staff working back home here in this country to support efforts to make sure there's preparedness in this country to care for patients with Ebola, and to work to help the authorities in Africa end this outbreak. Let me spend a few minutes now talking about some of the background on Ebola virus itself. Many of you may know a lot of this, but I think it's good to begin with a common understanding of what Ebola is and what it isn't. Ebola is in the family of the viral hemorrhagic fever viruses. It's an enveloped virus, as Chuck mentioned earlier, and there are some implications that has. It's, of course, a disease for which we have no specific treatment or vaccine. It's highly contagious and associated with a very high case fatality rate. It's important to remember that this is not the first time that we have dealt with Ebola, and so we actually know quite a bit about Ebola and how it's transmitted and how it's not transmitted from experience with more than 20 past outbreaks of Ebola virus and closely related viral hemorrhagic fever viruses since Ebola was discovered in 1976. The current outbreak is being caused by one of the 5 known subtypes of Ebola, the Zaire Ebola virus. We believe that Ebola, its source is an animal vector. We think it's bats, but we don't know exactly what species of bat. And we know that from past experience, what happens with Ebola outbreaks is that there is somehow spillover from the animal reservoir into people with subsequent transmission from person to person. The challenge with Ebola, of course, is that it is so very highly transmissible. The virus is present in very high quantities in many different types of body fluids of symptomatic patients. I think it's important, I'm going to emphasize this point a couple of times in the presentation, but only symptomatic people can transmit Ebola. People who are asymptomatic can't spread the virus. The issue is that there are a number of different ways that it can be spread from person to person. Through direct contact, and this is the most common way we think it spreads, through either broken skin or a mucous membrane with secretions from a patient who is infected with Ebola and have symptoms. But it can also spread through sharps injuries, through contacts with a corpse, or through indirect contact via some sort of a fomite. Again, we think those last 3 categories are much less common as a source of Ebola virus transmission. And experience with outbreaks indicates that the overwhelming majority of infections seem to occur through direct contact. The issue is that Ebola virus can be present in basically any body fluid that would be present on a person. So it's in our blood. It can be in saliva, urine, tears, semen. It can be in sweat, vaginal secretions, feces, and in breast milk. So it's really, the virus is truly pervasive in its presence in the human body of people who are infected. It's also important to note that it's present not only ubiquitously, but in extremely high levels. This is a graph showing the log count of log RNA count of copies of virus in the blood of patients who have Ebola virus infection. And as you can see, there is a difference between people who die from infections, who tend to have even higher levels of viremia than people who survive. But we're talking about numbers of virus particles in the millions, tens of millions, or even hundreds of millions in some of these patients. So the virus is present in so many different bodily secretions and present in very high levels. We know a fair bit about human-to-human transmission from our experience with past outbreaks. One of the important things we know is this point that I've emphasized, is that infected people are not contagious until we have the onset of symptoms. We've seen that in previous countries, and I think we've also seen that in this country. We know that the infectiousness of body fluids increases as people become more ill. The virus replicates, and the levels of virus that are in bodily secretions get higher and higher as people become more ill, which is, of course, why people who have died of Ebola, their bodies are so very infectious. We also know that human-to-human transmission via inhalation or aerosol transmission has not been demonstrated in any past outbreaks of Ebola. Share with you a little bit of data on household transmission that's come from one of the studies that was done. I'll point you to at the link at the bottom of the slide. If you're interested in really learning more about the transmission of Ebola virus, there's a very nice white paper on the CDC website that summarizes a lot of the data on what we know about Ebola virus transmission. In this outbreak, there were 28 cases that developed of Ebola from 27 primary patients. All 28 of those patients reported having some sort of direct physical contact with a known patient. And there are other studies that have shown similar findings. These studies have demonstrated that people who shared the same space as a patient with Ebola, they lived in the same house or were sleeping in the same room or area, but did not have direct physical contact with the patient, did in fact not develop Ebola. We also know a fair bit about transmission to healthcare personnel. The risks to healthcare personnel are very high. As you've heard in the current outbreak in Africa, there have been a very large number of healthcare personnel who have been infected, and this has been true of previous outbreaks of Ebola as well. The risk, as I've mentioned, goes up as the illness progresses, and so patients who are in the later stages of illness, who are, of course, the ones who are most likely to be present in healthcare facilities, are the patients who pose the highest risk. We have limited experience that suggests that invasive procedures like blood draws can increase the risk, which, of course, makes sense. There's no data on the risks during aerosol-generating procedures, and of course, one of the reasons is that there have been very few, if any, aerosol-generating procedures like intubation that have been done in some of these remote and rural areas in Africa where there's not the access to this type of medical care. A couple of studies that I think highlight both the risks to healthcare workers, but also highlight the ability that we have to protect healthcare workers. So in that 1995 Kikwit outbreak that I summarized on a previous slide, there were 80 cases of healthcare personnel who contracted Ebola before teams arrived to help them implement infection control precautions. After they implemented those precautions, there was only one other case in a healthcare worker, and it was a nurse who unfortunately reported inadvertently rubbing her eyes with soiled gloves. So the implementation of precautions was very effective in preventing spread to healthcare personnel. And that's exactly what was seen in an outbreak more recently, 2000, 2008, another outbreak in Africa, where 14 healthcare workers were infected before they implemented precautions, but none after. So I think there is evidence that suggests that we can implement precautions to protect healthcare workers. As I mentioned, there is no evidence to support airborne transmission of Ebola virus in humans. We know that from past outbreaks, people have shared airspace with patients and not become infected, so they were not exposed to Ebola by sharing the same air as an infected patient. And in that Kiklet study, once again, the presence of a cough in a case patient did not predict spread. So even the patients who were coughing were not more likely to transmit Ebola virus. There is some degree of conflicting animal data on this issue of airborne transmission, but I think it's very important to emphasize that there's no evidence to support aerosol transmission in humans. One important question to answer about Ebola virus transmission is to ask ourselves, is this outbreak consistent with past outbreaks? And so if it is, then we would suspect that transmission would be occurring via the same routes. And I think what is important to know is that this outbreak is very consistent with past outbreaks. The incubation period, the duration of the illness, the case fatality rate, and the reproductive number are all very similar to what we've seen in the past, which would suggest that the Ebola virus that's causing this outbreak is transmitted in exactly the same ways that we expect it to be transmitted, and so we can apply what we've learned about Ebola to control this outbreak. Say a few words about some of the clinical manifestations and lab findings, the clinical information about Ebola. Ebola typically has an acute onset, typically 8 to 10 days after exposure. The range has been reported as early as 2 days and as late as 21. There have not been human reports of people who have developed Ebola virus more than 21 days after an exposure. The initial signs and symptoms are nonspecific. They're the flu-like symptoms. Patients tend to develop the gastrointestinal symptoms after several days of infection. And these are the symptoms that, of course, create the tremendous risks for transmission, the vomiting, the watery diarrhea. Though Ebola is called a hemorrhagic fever, the hemorrhagic manifestations are present in a minority of patients, about 20%. And it's important to note, of course, if you're evaluating a patient who has been in West Africa, that there are a lot of other causes of these exact same types of symptoms. This is a very nice slide which summarizes the initial clinical experience with Ebola virus disease in the West Africa outbreak, and you can see that the clinical symptoms have followed exactly what we would predict based on past experiences. Almost all the patients have fever, 2/3 of them have vomiting or diarrhea, about 18% have developed some sort of hemorrhage. With respect to laboratory findings, again, I think these are very much what we as clinicians would expect in dealing with patients who have severe viral infections. Thrombocytopenia is common, often early leukopenia followed by leukocytosis then occurs, damage to the liver, so liver enzyme abnormalities. One of the big findings that we've seen in this country, and it's been one of the lessons learned, is that you often see very severe electrolyte abnormalities from the massive fluid losses. And repleting those electrolytes has been one of the key strategies in caring for these patients. It is a hemorrhagic fever, and you can see some of these coagulation abnormalities, and there's also been renal failure that's been reported in many instances. It's important for me to emphasize that we do have a number of very good diagnostic tests for Ebola virus. We have very sensitive and very specific tests for Ebola. The workhorse test for diagnosing Ebola is the real-time polymerase chain reaction, or PCR. It's the most sensitive test. It's more sensitive than a previous ELISA test. And it can be performed in a number of different laboratories around the country, either in what we call the Laboratory Response Network, or LRN laboratories that are regionally distributed throughout the country, and of course here at CDC. The interpretation of the test, what's been demonstrated is that it takes about 3 days for virus to be detectable in blood from the onset of symptoms. So if a patient is tested more than 3 or more days after their symptom onset, Ebola is very, very unlikely to be present, and other diagnoses need to be sought. However, if a patient presents very early in the course of illness, less than 3 days from symptom onset, and the test is negative, we do recommend repeating that test after 72 hours or after 3 days of symptom onset to be sure that the test is truly negative. There are a number of different other diagnostic tests that can be run. Most of these, of course, are either research tools or investigational tools, but the tests that have been run do help us really understand the serologic and immune response to Ebola. And that's summarized on this slide here, where you see viremia begins initially and then becomes detectable after about 3 days from symptom onset, usually with fever. There's an IgM-mediated response that appears to kick in early in the course of illness after about a week or so, and then an IgG immune response that starts at about 10 days, and that persists for many years and is detectable for many, many years after exposure to Ebola, after Ebola virus infection. We know that the early symptoms of Ebola can progress to very severe illness with hypovolemic shock, leading to multi-system organ failure, hemorrhagic disease, and death in a large number of cases. Case fatality rates in many outbreaks have been about 70%, and that's what's been reported in some of the early papers that have been published in this outbreak. We do believe, in our experience in this country, at least our very limited experience, is demonstrating that intensive care and early intensive care with aggressive fluid and electrolyte management may seem to actually improve the survival rate. We know that for patients who do survive, they do get viral-specific antibodies, and that antibody response does seem to persist for a long time, for many years after recovery. Not much is known about managing Ebola virus disease patients in the United States. Because prior to this summer, we had never cared for a patient with Ebola virus disease in a U.S. hospital. And I think that's something that we always have to keep in mind, is that fact that prior to a few months ago, we had no firsthand knowledge of caring for a patient with Ebola virus disease in a United States hospital. So all of this information that we've gathered really has been learned in the last few months. The recommendations from people who have been providing care is aggressive, supportive care, fluid management, electrolyte management, oxygenation, renal replacement if it's necessary. There are no specific treatments for Ebola. Ribavirin, which is an antiviral that we use in other types of viral infections, does not have any activity. There are some agents that have been tried in some of these patients. They've not been studied in clinical trials, so we can't really comment on the effectiveness. But obviously, we're in a situation where we are trying whatever we have available to us to try and save the lives of patients. Many of you have heard, I've heard as well, I'm not directly involved with the vaccine work, but I've heard that there are vaccine trials that are moving forward at a rapid pace, and hopefully we will see a vaccine come online and be available to help us curtail this outbreak. I'm going to focus the rest of my talk on issues pertaining to Ebola infection control in U.S. hospitals. And this has been an area that has been and remains fast evolving as we have more information. We do have a number, though, of recommendations that we are making currently, and I'd like to share with you what those are. And first and foremost, it's the issue of early identification being absolutely essential, both in reducing the risk of spread. The faster we get patients into isolation, the safer it is for everyone. But it's also better for the patients. We know that early identification and early treatment can be helpful in trying to get ahead of Ebola virus disease. The need to screen, there are two factors that go with this. The first is an exposure risk. People have to have some exposure to be at risk for Ebola. That means they've either traveled to an area where there's widespread transmission, or they have cared for a patient with Ebola virus disease in a U.S. hospital. So they have to have an exposure, and then they have to have some one of the consistent symptoms. And both of those are necessary for a patient to be considered at risk for Ebola. As many of you know, the United States has implemented a comprehensive and very aggressive entry screening and education process for people who are potentially exposed, which includes both people who are traveling from endemic areas and for our healthcare workers in this country who are caring for patients with Ebola. People who are traveling are being routed to a small number of airports where they're being screened on arrival and then being educated extensively about Ebola. They're being given information and given thermometers so that they can monitor their temperatures. And then they are being instructed to notify their state health department, the local public health authorities, when they arrive at their final destination. And then those health departments are keeping track of these folks and doing symptom monitoring with them for the full risk period, for that 21-day period. And that same type of screening is being applied, monitoring is being applied to healthcare workers. There are two types of monitoring that CDCA recommends. One is the most aggressive monitoring, which is called direct active monitoring. This is being done when people are in categories that we think are very high risk to develop Ebola infection. And this means that someone, a public health official, is actually physically watching that person, monitoring them, take their temperature, and assessing their symptoms on a daily basis. Most people who have lower risk exposures are doing what's known as active monitoring, which means that they take their own temperature and assess their own symptoms, but then they have to report every day to the health department. The level of the monitoring and the restrictions that might be imposed on people moving around are driven by the risks that a person has. And I've broken down the risks for healthcare workers here because I think those are the risks that we are focused on is the situation for healthcare personnel. And healthcare personnel can, of course, fall into different risk categories. In a situation where you are caring for a patient with Ebola and your PPE malfunctions, there's a rip or a tear or some part of it doesn't cover your skin properly and you get a splash, that's considered a high-risk exposure. Same situation if you're in a healthcare facility and there's transmission. There are healthcare workers who develop Ebola, and we don't know how they developed Ebola. Those healthcare personnel are in that high-risk category. People who are working in the United States who have patient contact, people who are working in endemic countries in West Africa, healthcare workers who don't have PPE breaches are in what we call the some risk category. And healthcare workers in the United States who have patient exposures with no PPE breaches fall into what we call this low-risk category. And those risk categories are important because they inform the type of monitoring that the person will fall into, and also it determines the restrictions that there might be on them going to public activities and traveling. So for healthcare personnel who are providing care to patients with Ebola in the United States who don't have breaches in their protective equipment, so they're in that low-risk category, and they are asymptomatic, they can go about their lives as normal. They can provide patient care to other patients, and they can do the things that they normally do. They do have to undergo direct active monitoring, but there are no restrictions on them traveling or caring for other patients or interacting in other activities. For people who have a breach, a failure of their PPE, or are working in a facility where there is unknown transmission sources, we think those folks are in a high-risk category. They really shouldn't care for other patients, and then there's some additional restrictions that would apply for them. We've tailored our infection control guidance for Ebola to be setting specific. We recognize that there are differences in the types of activities related to Ebola in different types of healthcare settings. And what we are, I think, increasingly understanding and increasingly moving towards is a strategy where every facility prepares, but prepares to play their role. We don't think, for example, that every hospital in the United States should plan and expect to hospitalize a patient with Ebola virus for an extended course of care. We think that's probably best done at a smaller number of hospitals who can be specifically trained and resourced to do that. So let me talk through our guidance then from the perspective of different care settings and what the guidance is. And let me begin with ambulatory, non-emergency department settings. And we really believe that patients should generally not be evaluated for Ebola infection in these types of settings. These are doctors' offices, pediatricians' offices. These clinics are simply not set up to do this type of evaluation. They don't have the types of personal protective equipment for the most part that would be needed, and they really don't have access to a lot of times the laboratory testing that would be helpful in doing this kind of initial evaluation. We think that the best strategy, the best approach to provide optimal patient care is to ensure that patients are not going to these places to be evaluated. We think there are a number of ways that can help with that. One, of course, is the fact that we are doing this direct, this active surveillance, this assessment and monitoring of people who are at risk. So we know who these patients are. We will know at the very first sign that they are developing symptoms, and then we can direct them to the right place to go for therapy, so they won't just go to their doctor's office or their pediatrician's office with symptoms that could be Ebola. We also think that the ambulatory clinics can play a role here. Many of you who work in these clinics know, or people who go to clinics like I do know, that there is usually a telephone system either when you make the appointment or I get a follow-up phone call from my doctor the day before my appointment to remind me that I have an appointment. And we've seen a lot of folks have incorporated this type of Ebola screening into their telephone triage, where the appointment reminder says, you know, if you've been in West Africa in the past 21 days, please call our clinic so we can discuss. The other time that we can work to identify patients, again, to reduce the risk that people are going to unexpectedly come to these places, is to use signage. To put signs on doors outside the clinic to let them know if you have an exposure risk, if you've traveled and you have symptoms, you need to let our staff know immediately. Now, in the rare event, and we think the unlikely event, that a person with Ebola exposures and symptoms comes to an ambulatory clinic, what we recommend is that you immediately place that patient in a private room, and ideally this could be done by having one of your staff stand at a distance from the patient and simply verbally direct them down the hall or wherever they need to go into a private room where they can be isolated and where you can close the door, and that you immediately notify the health department who can help you arrange transfer to a facility where assessment can be done. We really recommend that in these ambulatory clinics that because they don't have the personal protective equipment that would be needed, they avoid direct patient contact, especially if the patient has bleeding, vomiting, or diarrhea, where a really enhanced level of protective equipment is necessary, and it's protective equipment that we really think is very unlikely to be available in an outpatient setting. We would recommend that folks not have contact with those patients, that they call 911 and get help immediately. If you have a patient who's not bleeding, having vomiting or diarrhea, and you absolutely have to have contact with them, we recommend that people use protective equipment that we think might be available in an ambulatory setting, eye protection like a face shield, maybe a surgical mask, a gown, and 2 pairs of gloves. But again, we really recommend that patient contact not occur in these settings because most places don't have this type of protective equipment. We've mentioned 911. The 911 call centers, EMS call centers, I think have done a very good job of handling this. Most of them, I think all of them, have now incorporated these Ebola screening questions into their 911 calls, and the emergency medical responders have been given information and training and the right equipment so that they are prepared to come to your clinic if necessary and pick up the patient and transport them safely. What about guidance for emergency departments? Well, unlike the ambulatory setting where we don't think evaluation would occur, we do think that in the emergency department there probably is a need to be prepared. Some of these patients may end up calling 911, may end up presenting to an emergency department. Again, I think there is an effort to work collaboratively, closely between health departments and the healthcare system to maybe try and designate some certain emergency departments or areas where patients would go for initial evaluation. But we also think that emergency departments do need to be prepared, and many of them already have been doing these types of evaluations of patients with risk factors. We think that one of the keys, again, is early identification of these patients. Point of entry screening, unfortunately here you don't have the luxury of an appointment, of an advanced phone call that can be made. So your screening needs to be point of entry screening. Signs, I've seen these done very well in many different places. Signs at the entry points telling people if you've traveled, if you have these symptoms, let us know immediately. And then as a backstop, the initial point of triage, the first person who interacts with the patient, again, reiterates and asks these same questions. If you have a patient who has exposure risks and they have symptoms, you need immediately to activate your Ebola management plan. You need to get that person quickly into a private room, ideally one with a bathroom or a portable commode. Again, we think this can be done by having your staff stand at a distance and simply verbally direct the patient to the room where they need to go, and then immediately have someone notify the health department and the infection control department in your hospital. Once you've got the patient in the room and you have notified public health, you are ready to begin assessment and providing care, implementing your Ebola management plan and your correct personal protective equipment. Now, obviously, you can't activate your Ebola management plan if you don't have an Ebola management plan. So one of the keys, of course, to preparedness is to have a plan that's been developed. And I've outlined here a number of the different considerations that need to be part of this Ebola management plan. There needs to be a facility manager. Someone needs to implement this plan and needs to develop the plan and then oversee the implementation, making sure that all aspects are being considered, that you have the supplies that you need. You need to know where you're going to put the patient, and you need to know where the healthcare workers are going to put on and take off their protective equipment. You need to designate a very small number of staff who are going to provide care. This is not a situation where we want lots of people entering and leaving the room, so it's good to have a really small cadre of staff who would do these evaluations. Those staff need training on how to put on and take off their protective equipment. You'll need supplies of protective equipment, a very limited number for training. And that's, I think, a key. It's to order a limited supply of protective equipment to manage whatever you think the number of patients you might see are. You need to have a plan for lab testing, a plan to clean the environment, and then a plan for waste management. We have two different options that we recommend for personal protective equipment for the evaluation of patients who might have Ebola virus disease. If you encounter a patient who is in the early stages of infection, and we think that most of the patients who will have Ebola, now with the aggressive monitoring, we will be seeing these folks at the very earliest stage of infection, where maybe their only symptom is a fever. In a patient in that situation who's not having bleeding, not having vomiting, not having diarrhea, the risk of splash is essentially zero because they're not having these types of secretions. And so the protective equipment that you could use there, we recommend, is protection from droplets in case they happen to maybe cough or sneeze. So a face shield and a surgical face mask, which would protect you from droplet exposures of your mucous membranes of your face, a gown to protect your clothing and your skin, and 2 pairs of gloves. If you are seeing a patient who is not stable or has bleeding, vomiting, or diarrhea, The type of care that you'll be providing is obviously going to be more aggressive. There's a much higher risk for exposure, and in those situations, we recommend that you follow the guidance that we provide for personal protective equipment for hospitalized patients, and I'll cover that in just a couple of minutes. Let me talk a little bit about the labs. There is guidance available on the CDC website for how to manage laboratory specimens for patients who either might have or do have Ebola. Clinical labs can safely handle these specimens. There are recommendations for them to use either biosafety cabinets or plexiglass splash shields to minimize the risk of exposure. And there is guidance that indicates that samples can be run on routine lab equipment, and that after you've run these samples, you would follow the recommendations and use the safety features that are in place from the manufacturer that discusses enveloped viruses like human immunodeficiency virus. One of the key points that I'd want to emphasize when we talk about emergency department evaluation of people who might have Ebola is that of the 400 plus patients who have been evaluated in our U.S. healthcare system who have been thought to potentially have Ebola, there's been only one case that's been diagnosed in an emergency department. So the overwhelming majority of patients who come to EDs to be evaluated don't have Ebola, and once Ebola is ruled out, you can provide care, all aspects of care, lab testing, environmental cleaning, waste management, as you would for any other patient. What about hospital management? Well, one of the issues and one of the things that we've learned about hospital management, this is providing the full course of care for a patient who we now know has Ebola and needs to be treated for confirmed Ebola virus infection. We think that this is best done in a small number of hospitals that are well prepared, well trained, well equipped, and well supplied to provide that care. It's not every hospital, but a select group of hospitals. And right now, the federal government, state health authorities are working collaboratively with hospitals who are interested in providing this care to try and find the facilities that would be most prepared to do this and to help them in their efforts to prepare to provide this care. Limiting the number of hospitals obviously will help us focus our training and support efforts to these places that are going to be providing this care. CDC is working with the Office of the Assistant Secretary for Preparedness and Response. We're working with state and local health departments. We're working with hospitals that have expressed an interest in doing this. We're actually sending teams from the CDC and folks from ASPR are joining these teams to go to these hospitals, to talk with them, to see what they're doing in terms of preparations, to share lessons learned from other hospitals who are working to get ready, and share lessons learned from hospitals that have done this. Emory, Nebraska, the National Institutes of Health, Bellevue Hospital. Working with these folks to understand barriers and what the solutions might be to help them get ready to potentially provide that care. We also are committed to continuing this work. If there is a patient who gets hospitalized at one of these facilities, we will work with state and local health departments to send a rapid response team to get on site at that hospital to support their infection control and clinical issues with taking care of a patient with Ebola. We know that safe and effective care for a patient who's hospitalized with Ebola is very complex. It requires a lot of advanced planning and training, supplies, and practice with those supplies. The good news is that we do have experience now from doing this in the United States, and we can learn from that experience so that we can do this safely. Getting ready to hospitalize a patient for Ebola actually involves exactly the same steps that you would take to plan to evaluate a patient for Ebola. So these are, as you can see, essentially the same steps that I highlighted previously in the plan for an emergency department Ebola plan. The protective equipment that we would recommend is different from evaluating a patient who only has a fever. So the protective equipment for the personal protective equipment, or PPE, for the care of patients who are hospitalized with Ebola really is quite extensive, and it involves the principle of making sure that there is full coverage of the healthcare personnel so there's no risk of a splash exposure. This is just a schematic, a picture of what this looks like, but it's a face shield to protect the eyes. We do recommend respiratory protection in the form of an N95 mask or a powered air purifying respirator. We recommend a headpiece to cover the head, which can either be built into the PAPR or as a separate piece if you're using an N95. You would wear a gown that's either fluid resistant or impermeable, depending on the risk of the exposure. For hospitalized patients with bleeding, vomiting, or diarrhea, it really needs to be this impermeable gown or an impermeable coverall. 2 pairs of gloves with an extended cuff. An apron for patients who are having vomiting or diarrhea or bleeding, and then boot covers. It's critical to note that this is protective equipment that we're not used to as healthcare workers. This is not the type of PPE that we wear and use in our daily patient care activities, which means that putting it on is challenging, and taking it off without contaminating ourselves is very challenging. So when we're using equipment that we're not accustomed to, where there are substantial risks for self-contamination, we know that we need to practice extensively to get ready for it. We recommend that in addition to training people to get ready to do this, that there at all times be an observer, someone who's trained in protective equipment, who watches every time a healthcare worker puts on or takes off protective equipment. And that way there's someone who can watch them to make sure that they're doing it safely. We do have some guidance for the sequences of putting on and taking off protective equipment, and there are some videos that are online on the CDC website at cdc.gov/Ebola. Under the link for healthcare personnel, there are these videos that walk you through the donning and doffing sequences for all of our recommended types of protective equipment. But there are 2 key points that I want to emphasize here. The first is that watching a video is, of course, no substitute for hands-on practice. The videos are great as training guides, but it's critical to practice using your protective equipment. And it's also important to note that the videos are just guides. We know that there are different ways to safely put on and take off protective equipment. And you may have procedures in your hospital that are different from what's shown in the videos. And we think that's not only acceptable, we actually think that's good. We think it's wonderful when people think through these sequences to the point of figuring out that, wait a minute, this way actually works better for us. The key, in our opinion, is to use these videos if they're helpful as training guides, but to practice yourselves and to use the sequences that are most effective in your experience. Let me say a couple of words about why we recommend a respirator. Ebola is not transmitted via an airborne route. I emphasized that earlier and showed you some of the data that supports that assertion. But we are recommending respiratory protection. Why is that? Well, what we've learned in the caring for patients with Ebola in the United States is that we are providing, of course, aggressive and advanced medical care that might require aerosol-generating procedures like intubation. And the need for these procedures might develop unexpectedly. Putting on and taking off Ebola protective equipment, especially taking it off, is time-consuming and needs to be done very, very carefully. So we don't want people to ever be in a situation where they have to put it on or take it off quickly. So what our recommendation is built on a rationale that when a healthcare worker enters the room, they should be protected and ready in the event that there is an aerosol-generating procedure. And that's why there's a recommendation for respiratory protection. We recommend 2 options, either a fit-tested, NIOSH-certified N95 respirator or a powered air purifying respirator. Both of these options can be used and have been used to safely care for patients with Ebola virus disease in the United States. Emory University is using the PAPRs. The University of Nebraska predominantly uses the N95s, and both of them, of course, have had successful experiences safely providing care for patients with Ebola. We also know that both of these types of respiratory protection has been used for decades to safely care for patients with true airborne diseases like tuberculosis, including during aerosol-generating procedures. So we really think that both of those options provide excellent protection for healthcare workers who are caring for patients with Ebola. A few key lessons learned about personal protective equipment that have been shared by the folks who have been doing this and dealing with this. The first is that point I mentioned earlier. It's critical to have an observer who watches all steps of putting on and taking off the protective equipment. Some folks have also noted that it can be really helpful to have an assistant who helps with removal, kind of what's taken from the hazmat world, the idea of a buddy who helps you take off the equipment. Now, we believe that the observer and the buddy should be two different people. We don't want to have a situation where the observer is trying to help the healthcare worker take off the equipment. We really think that the observer's job should just be to observe. But in situations where a healthcare worker is trying to take off a PAPR, that can be a little bit challenging, especially if you're not really comfortable using that equipment, and having a buddy who's there to help can be helpful for that. Of course, when you're taking off your protective equipment, the buddy and the observer will also need to be wearing protective equipment, and we do have a recommendation for what that would be in our guidance. It's important to inspect and even decontaminate the protective equipment before you take it off. This is pretty different from what we recommend in all other circumstances, but we do believe that if you come out of the room and there's evidence of visible soil on your protective equipment, on the gown, the coverall, the gloves, cleaning the protective equipment before you start removing will help reduce the risks of self-contamination. There are a number of steps where we recommend hand hygiene during the doffing process, and again, we think that'll help reduce the risk of contamination. And finally, an important lesson that's been learned is more protective equipment is not always better. We've heard from folks who have tried, adding an extra gown or more pairs of gloves or additional shoe covers or taping the protective equipment so that it all stays together. We've heard from them that, doing these types of things actually makes it more difficult to provide patient care, which can make that care less safe, and actually might increase the risk of contamination during removal. Let me close. I'll say a couple of words about disinfection and waste management, because there are some special considerations here. For disinfection of patient rooms for when a patient is hospitalized with Ebola virus, we think that the daily cleaning of the high-touch surfaces like the bed rails should be done by the clinical team who's already entering the room to provide care. We think this will help minimize the number of people who are entering the room on a daily basis. The terminal cleaning should be done by our environmental services staff, our experts who know how to properly clean patient rooms to get it ready for the next patient. It should be done by our environmental services staff who have training and experience and who are trained to use the same protective equipment that our healthcare personnel are wearing. Lots of things work for disinfecting Ebola virus. Ebola is an enveloped virus and is, as such, the easiest of the viruses to kill and remove. A lot of different products are very effective at killing Ebola. Alcohol-based hand rubs, for one, are very highly effective. And any EPA-registered disinfectant or wipe that has a label claim against a non-enveloped virus, and the best example is norovirus, would be highly effective against Ebola. I've told you that Ebola is an enveloped virus, and we recommend using a disinfectant that is one level higher. So a disinfectant that would work against a non-enveloped virus would give you a one level higher than you actually need to take care of and kill Ebola. Waste handling has been one of the big challenges with this issue of hospitalizing patients with Ebola, because infected waste from an Ebola patient is governed by some very specific rules from both the federal government, the Department of Transportation, and state and local laws. And it's categorized as Category A biohazard waste. So there are a number of regulations that your hospital that's going to be caring for a patient would need to be familiar with, or that your emergency department staff might need to be familiar with. That guidance is extensively detailed on the CDC website, and the links are provided here. The thing that I would like to mention is that if the waste, once it's been autoclaved or incinerated or otherwise inactivated, it's not infectious waste anymore, it's just waste. I'll close by emphasizing that the current Ebola epidemic poses huge challenges, both in Africa, where the outbreak, the epicenter of the outbreak is, where there are so many people who have been infected, but also around the world. Hospitals, healthcare systems around the world are working hard to prepare to be ready to care for potential patients in our country. We know that the best way to protect us in the United States is to continue to work aggressively to stop the outbreak in Africa. Until that outbreak is controlled, our U.S. healthcare facilities need to be prepared to follow the relevant guidance, to play whatever role they will be playing in managing patients with Ebola or screening patients for Ebola. And it's important to emphasize that, of course, those roles are very different in our different types of healthcare facilities. As I mentioned at the outset, I want to close by emphasizing that we view this as a partnership. We are here to help you in your efforts, and so we really want to stay in touch with you, to remain engaged with all of you, to understand what you need, what we can do to be helpful to support your preparedness efforts. And so with that, I'm going to turn it back over to Chuck.
Great. Well, thank you very, very much. This was terrific. You're right on time. And so what we'll do, Arjun, is we'll just ask a couple of polling questions, and in the lower right-hand corner of your screen, we'd like to capture your questions. Now, Arjun, I've had a number of questions coming in on email that we'd also like to maybe address after the webinar, because we won't have enough time to cover all of them, but we are so appreciative of what you've covered. And what we'll do here also, Arjun, is provide you and your team the free text entries that you will get from our test bed here. So the polling questions are in the lower right-hand corner of your screen, and the first question is, what additional topics would you like covered regarding Ebola and HAIs? One of the questions you'll have on the next page will be, would you like a three-part series of a deep dive on the real tactical and specific issues regarding the hazard zones for treating HAIs, with some emphasis on Ebola, but kind of covering the waterfront? So we'd love a free text entry of any of the additional topics that you would like to have covered regarding Ebola and the HAIs and some of the real challenges you face with them. And Arjun, we had some questions coming over with the transom regarding the PPE issues and some specifics. So we're going to have, I think, some good questions there. The second question is, would you like regular updates on best practices, including cleaning innovations used to protect against contagious infections? We've had an enormous response from our test bed regarding the issues of being able to make sure that all of our environments are clean. We've covered a number of outbreaks that have occurred in the procedure labs, which are going up, and as hospitals are acquiring new systems and new practices and additional outpatient facilities and imaging facilities, we're finding that their protocols are not up to the level of the hospitals, and it's a big jump to be able to get the same standard of care. So the question is, would you like regular updates on best practices, including cleaning and the end-to-end sort of approach? The second set of polling questions are, would you support, and the statement is, I would support a three webinar series with an end-to-end approach where we could identify all of the potential hazard zones for prevention of HAIs, including transmission of Ebola, but also prevention prior to, disinfection, sanitation, and an end-to-end approach that would include getting rid of the waste and cleaning the facility and caring for the caregivers as well from the beginning of having a potential scare or an episode right through until after, so that we could map the care processes and identify where the hazard zones are, and then map the leadership practice and technology solutions that may be available to it. So this is a deep dive, 3-part webinar series, free, as all our webinars are, but it would be out of the typical cycle of our typical webinars. And then the final question is, again, a free text entry question. And Arjun, we end up with 3 or 4 pages of single-spaced problems, issues, and questions from these free text entries. So we'd like everybody to just put in, what are the biggest problems that you have with any of the healthcare-associated infections, Ebola, flu, any of the issues that you're running into today, and we'd like to have you submit those to us as well. And you can continue with that as we move forward. But what we'd like to do is introduce Dr. Greg Boats from MD Anderson. And Greg, it'd be great if you could, we talked a little earlier about reducing your 10-minute presentation to maybe 8 minutes, 7-8 minutes, so that we can have more time with Arjun on the questions in our reactor panel. But Greg, and we'll be bringing Greg back, who's a regular speaker for us and working with us in patient safety and quality. He's the medical director of the Simulation Center there at MD Anderson. He's a professor of the department in the Department of Critical Care at the UT MD Anderson Cancer Center. He received his medical degree from George Washington University, and then undertook his residency training in anesthesia and fellowship at Stanford, where he also continues to give time once a year and fly with the helicopters, training nurses and physicians in care of critical care of patients. He's also completed a medical simulation fellowship at Stanford with Dr. Gaba, and is a real champion of training, having helped develop certification programs for other countries around the world. And we're working very closely with him on our continuing medical education and maintenance of certification programs. So Greg, would you please take it away, and thanks so much for abbreviating what you were going to cover so we have a little more time with Arjun.
Well, thank you, Chuck, for that introduction, and it's a pleasure to be with you this afternoon to discuss this topic. And I will abbreviate my presentation a bit so we have a chance to have a rich discussion. I took the liberty of changing my topic a little bit to practical preparation and readiness. And the takeaway message for this presentation for all of us should be that we need to practice what we preach. As we've heard over the last hour or so, Ebola has made it to the United States, and that has brought a certain amount of worry and concern on the part of healthcare providers. And I think you can all appreciate that it could have been us. It could have been my emergency room. It could have been your emergency room. And we often wonder whether we would be able to muster the appropriate response to deal with this very significant public health issue. I'm very concerned with the fact that 2 healthcare providers that were following guidelines and providing care to this very sick patient actually contracted the Ebola virus. And the lingering question there is, how did that happen? How did that happen? We were told at the time that this patient presented to the Dallas hospital that our usual personal protective practices and our infection control practices, including universal precautions and contact isolation practices, should be adequate to protect healthcare providers in that circumstance. And I think we can all appreciate that perhaps some of that guidance has changed over the last several weeks as we've moved through this experience of the first patient in the United States and learned more about best practices, as we heard in the previous presentation. I think we can all appreciate that there are risks involved in the delivery of care to our patients in our healthcare model, and we do as much as we can to identify and mitigate those risks in our environment. We've spent a lot of time and a lot of resources trying to eliminate healthcare-associated infections in our patient population, but we haven't been able to eliminate it entirely. And I think the Ebola event, as Dr. Denham described, was our canary in the mine. This was a very significant infection that brought to bear a lot of attention about our protection and infection control practices, and perhaps there's something in that has been preventing us from reducing our healthcare-associated infections to zero. If we go back 15 years or so, the Institute of Medicine report To Err is Human conservatively estimated that the excess deaths in the United States per year were somewhere between 44 and 98,000 attributable to medical injuries and specifically to medical errors. If you think about that, that makes being an inpatient in a U.S. hospital one of the leading causes of death. The key findings in that report were that errors occur because of system failures, and in order to prevent those errors, we need to design safer systems of care. In the follow-up report, Crossing the Quality Chasm, the Committee on Quality of Healthcare in America was very careful to make this following statement, and I think it's very important for us. Between the health care we have and the care we could have lies not just a gap, but a chasm. So what's the problem? Well, to paraphrase my friend and mentor, Brent James from Intermountain Healthcare, the science and technology of our current healthcare system is the best the world has ever seen, and it continues to improve, while the performance of the American healthcare delivery system leaves much to be desired. In fact, there's a failure of execution. And I think if we honestly reflect on the care that we deliver in our hospitals, we can identify events that take place that are clearly failures to execute the plan that we have in place for the safe care of our patients. If we drill down a little bit to look at what are the elements of the failure of execution, I think we can describe a number of performance gaps that are contributing to those defects in our system. That is, there's often a gap between how we think we behave and perform and how we actually behave and perform. And within that gap, there is a potential for efficiency waste, significant patient safety lapses, and actual harm to our patients. So how do we go about reducing these performance gaps? Well, it reminds me of the old adage, how do you get to Carnegie Hall? Well, the answer is practice, practice, practice. And this is a proud parent moment. This is a picture from the night several years ago when my then 9-year-old daughter performed at Carnegie Hall in New York. But back to our topic, if we think about it, how do we reduce performance gaps in our system? It's the same answer. We need to practice, practice, practice. And I look forward to the opportunity to come back to a future webinar to talk more specifically about how we can do that with some of the technologies and techniques that we have available to us. But I want to leave you with one thought. I think healthcare is one of the only high-stakes industries that works in a production mode perhaps more than 90% of the time. We take very little time to stand down and actually critically evaluate our performance, evaluate our outcomes, and work to try to correct those deficiencies in our healthcare delivery that might improve the outcomes in our patients. So I'm going to stop there, Chuck, and look forward to the conversation with the additional panelists.
Great. Thank you so much, Greg. I really appreciate it. And so next what we'll do is we'll get some reactions from our reactor panel. The first is Dr. Darren D'Agostino, who is the chairman of the Department of Medicine at the University of North Texas Health Science Center. And kudos to you. Your president, his last hospital post won Baldrige this last week, which is fantastic. Dr. Mike Williams, who was on our webinar a couple of months ago. And so kudos to you there, Darren. He's also an associate professor of internal medicine. And he also is involved on the Texas Task Force, which he may share. Why don't you share that with your comments on what you heard, Darren, and maybe some advice to us from your perspective.
I would love to. Thank you very much for that introduction, and congratulations, Mike, if you're on the line. These were great presentations, and I really appreciate being part of this. Dr. Boats mentioned a couple of things that I think are critical here, and the first one would be behaviors, talking about behaviors and those behaviors developing with practice. But what I think is important about that is once those behaviors become rote and we start doing them correctly, those behaviors then get modeled by others, and you get a chain reaction of successes from that. So I absolutely agree that there are that practice is going to help here. There were a couple of other things that were mentioned in the previous talk, and I think one of the things that I would like to highlight is what actually wasn't focused on, but is a critical element of this that ties directly into it, and that is the pre-hospital care. With these patients and with emerging infections, we have pre-hospital care that also has to be as diligent as the emergency room and the ICU staff. In fact, MedStar here in Fort Worth put together an entire program and outfitted a rapid response vehicle that was able to handle, should there have been a need, anybody that was infectious with minimal spread of disease. And I think that is something that we would need to focus on. There were a few other issues that had come up. One of the things I think we can do is take some of the elements of the learning experiences and roll them into these hospital-acquired infections. And I think if I can, just to mention the 5 big ones that I look at: bloodstream infections, pneumonia, ventilator-associated pneumonias, urinary tract infections, and surgical site infections. All of these require most of the things that we just discussed. And they are modifications, I believe, of public health initiatives, just taking it into a local event or a local venue like a hospital. And so I believe you're absolutely right. Let's not waste a good crisis and use this to move forward. Lastly, the task force has identified a number of other people in the audience that need to know about this. So if I can, just very quickly, healthcare professionals, including trainees and students, we do have to have active participation with that. Emergency responders I just discussed. Animal health professionals came up in a number of different comments. Public transportation, many of our patients going to clinics don't have the ability to drive, and they rely on public transportation. Community health workers that are moving out into the community, and then pharmacists are also a critical element to this. So why don't I stop there and let the other panelists talk.
Thanks, Darren. And I'll go to Terry and then Mary and then back to you, Arjun. And we've got a number of questions that are coming in that we won't be able to answer completely, and we may extend a little bit longer than our usual time to address some of them. But we'd like everybody to keep submitting your questions either by email or on the webinar function, and then we'll make sure to get back to you and add them to our transcripts. And also noted that the envelope versus non-envelope moniker on one of our slides was wrong, which we'll correct. So we'll also correct the slide deck for you too, and maybe add a few things. Terry Wheat is a nurse, is a board member of one of our safety net hospitals treating the most vulnerable populations that we have in Chicago, and is also a clinical leader. She's the director of patient care services and chief nursing officer at Shriners Hospital for Children in Chicago. She's been a delight to work with and really brings great core values to the discussion. And I think, Terry, your comments regarding someone who's a board member who really has one foot in, as you've said before, anything clinical that happens to the patients in the hospital where you're the lead clinical leader, you have one foot there, but then you have the other foot at another hospital as a trustee where the resources get allocated. You have a very unique perspective.
Well, thank you so much for allowing me the opportunity to participate on this important issue. And, you know, the information that we have heard from both our presenters has been just fantastic. One thing that's important for me, especially as a board member, is to understand that all hospitals are not all alike, and so we cannot all do everything. And so it was really, I agree that we need to know what our role is in this partnership. And so as a board member, to know the role that our hospital plays, and then to make sure that the resources are allocated so that that we do a good job with those resources and allocate them to the proper places that they need to be. Also, with this Ebola crisis, it made me understand and appreciate more that the world is becoming smaller, and that it's not a long distance away, it's right at our front door. And so we do have to be prepared, and we also have to learn from our experiences. And so I do believe that being prepared and being correctly prepared is important, not only as a nurse leader, but also as a trustee. So thank you.
Well, thanks, Terry. And again, we think, you know, the actuators, the frontline actors are nurses taking care of these patients, and that's why we're so blessed to have both you and Mary Foley on the call. And Mary is now on, and she's a professor at the University of California in San Francisco, UCSF. She has been the director of the Center for Nursing Research and Innovation. She's been a co-author with us on a number of papers. She was also a real lead on the National Quality Forum Safe Practices, the patient advocacy dimension, and she also teaches leadership and is developing leadership programs. And so, Mary, your response here and your perspective as both an educator, nurse, and you know this challenge that we face, how we cannot waste this good crisis that we have to really focus everybody on the broader picture of all the infections, in addition to what Arjun covered.
Thank you, Chuck. I am so appreciative of the opportunity to link, you know, our current focus on the Ebola crisis, which, as has been said, is really in West Africa, but it has driven some additional attention to infections and our lack of preparation and our lack of attention to that critical issue, still infecting hospitalized and institutionalized patients all over the country. So something good will come of this, much good will come of this. I am struck by how quickly best practices are spreading. I was active during the AIDS epidemic, and it took many, many more months and actually years for us to learn from each other the principles of new infection practices then. Now we're able to share on webinars and social media much more quickly to everyone's benefit. So I just want to share very quickly, I met Cole Edmondson this week, who is the chief nurse at the Dallas Presbyterian Hospital. And I can only say how proud I was to meet such a nurse leader who is proud of his staff. His 2 infected nurses are preparing to return to work. He went in the rooms with his nurses to give care directly, learned firsthand, expressed his own fear, faced it, and led throughout. And his team understands what leadership is, the execution of leadership and learning. And he's now in a position to share with us those best practices and the human side of having to go in and tell his own staff that they've been infected. And he made that his job to do and no one else's. So that's the kind of lessons we're learning from this, how to wear new equipment, how to be observant in new ways, and how to lead. And I think good things will come of this, and thank you for this webinar.
Well, great. And Mary, I'm so glad you brought it up because, Arjun, I'm coming back to you. I mean, when I saw the 60 Minutes program of the caregivers that stepped up, it just made you so proud to be in healthcare, be in medicine, be in all of this, and that was terrific. Now, the one thing, Arjun, that we have over and over and over again as questions from our audience, and we even saw it some on the questions coming up today, is the working with the personal protective equipment and sanitation and getting rid of the waste and and those issues. Kind of an end-to-end approach to this in terms of also cleaning. Do you think that we'll be seeing more coming out from the CDC on this? You mentioned that the uniqueness of our organizations, and it appears that we're really going to be needing to develop better and better procedures for cleaning and for doffing and donning the gear. And I can tell you personally, we shot video of doffing and donning the gear, and I've talked to others too that I think I would have infected myself, no question, or contaminated myself because it's really hard to do. Arjun, thoughts there on will there be more coming, and any advice there on how we can kind of team up to out at the front line to get better at it?
Yeah, so a couple of issues there. With respect to the PPE donning and doffing, we've gotten lots and lots of comments from folks about the sequences, about the videos with good suggestions. And so, we will expect over time to be updating guidance documents, and in a situation like this, guidance always evolves, and that's one of the reasons why it's so important to keep going back to the CDC website to look and see what's changed. With respect to cleaning and disinfection, if there are additional gaps and needs out there, we would love to hear about them. We do have quite a number of recommendations on the cleaning and disinfection issues, on the waste management issues that are out there already. But always in one of these fast-evolving outbreak situations, guidance gets updated on a regular basis. Dr. Frieden, who's our agency director, likes saying, it's a great quote, that we will bring you what we know when we know it. So as we learn more, as we hear more, better ways to do things that are not clear, we will work to clarify those and provide new information.
So Arjun, our thought is that if we get a big response on having maybe a deeper dive webinar series that takes it end to end and identifies the hazards that may not be hazards but we're afraid of them, or real hazards where we could improve, do you think that is a good idea?
Yeah, I think that where there's a need for information, then providing that information to help people do what they need to do safely and effectively is always helpful. So we're happy to stay in touch. Chuck and you and I are obviously in regular contact with each other, and so we'll stay in that regular contact and work to try to meet the needs of the folks who get so much valuable information from you all.
One question that we had was regarding the cleaning, and you had mentioned on the Greater New York webinar, which was terrific. Two questions there. Is the first one was, when in doubt, you said to use the EPA-registered cleaning agents that would work for norovirus, and we know that there's been some success there with the cruise lines and norovirus, and improvements there. And do you still recommend that? And the second thing is the video with the Greater New York the latest off and on video that we could send people to, or are there going to be others in terms of PPE?
The recommendation for disinfectants that would work against norovirus are still current. That would be highly effective. Norovirus is a non-enveloped virus. It's hardier in terms of environmental survival than Ebola. Ebola is an enveloped virus and easier to kill. And so we recommend, basically going one step up. So rather than using something with a label claim against an enveloped virus, we say go one step up. Pick one that has a label claim against a non-enveloped virus, and the best way to know that is, of course, one that has a label claim against norovirus, and those should be very, very effective in killing Ebola virus on surfaces. Yes, there are a number of different videos that are actually available online. I'm most aware of the ones that we have online. We have videos, one that was produced in collaboration with Medscape, and then we have a series of videos that were actually produced in collaboration with the Armstrong Patient Safety Institute at Johns Hopkins Hospital, in collaboration with a number of different external partners, including, I believe, Apple Computers, the University of Miami in Ohio. And those videos are actually, they go through all of the different sequences. So putting on, taking off the PAPR option, putting on, taking off the N95 option. So those are the ones that I'm aware of. All of them are available up on the CDC website, cdc.gov/Ebola. And if you click the link for healthcare professionals, all of those videos are there.
Great. Well, we'll add them to the slide deck and put them up as resources, Arjun. Just a couple, as you skim over some of the questions, we're a few minutes over, but where any of the questions that you see you would like to answer in the right panel, instead of me moderating them and that kind of thing, in case there's something you think is really important. And we're going to collect these questions, Kyle, and then we'll get answers for everyone, because we couldn't cover all of the questions. But Arjun, are there any that jump out at you?
Yeah, so there's a question about human remains. There is specific guidance on safe management of human remains, so if people have questions about that, they can see that. I think there's a very nice thought here about this idea of observers and buddies for every time we use protective equipment, and I think what that speaks to, which I think is very, very true, is that we need better training on how we use personal protective equipment in hospitals. I was taught how to put on and take off PPE by a senior resident in that classic see one, do one, teach one mode, and I don't think that's the right way to do this, and we need to do better on that. let's see, there's one here. The issue of the dry patient, the patient who's not having bleeding, vomiting, or diarrhea, and there are some different options that are recommended there, and I would point people to the emergency department guidance to see what the differences are, what is there. And then a couple of questions on disinfection, which Chuck, I think we've just covered. And then a question, a nice one here about the expectations for facilities to prepare. And if you have a one-bed emergency department, how would you safely do this? And I think the issue there is increasingly we're moving to a strategy where we're working very hard to identify the facilities where evaluation and care for patients who might have or do have Ebola could be done in a very limited number of places. I think the monitoring strategy that's in place was really going to help us with that, and it's really going to allow us to direct patients to places where this can be done safely and effectively.
Great. So we anticipate that what we'll do with the deep dive webinar, if we get a strong response, is to take the very common scenarios that are articulated in many of the questions, the ED visit, the follow-up, the cleaning, and just take an end-to-end approach with panelists who are experts in each field in emergency medicine and those that are caring for patients and others. But I know we're over time, which we rarely do. People like for us to finish on time. We'd like to thank everyone for their response. Greg, we're going to have you back, as well as Darren. Thank you so much. Terry, thanks for expressing what you did regarding the governance leaders, because I think if we can get our governance leaders activated by the Ebola energy on all of the HAIs, and I'm going to ask Arjun just to address what we could learn from Ebola to take all across the system, that would be great. Mary, it's always fantastic. We'll go to Arjun. Any last words regarding what we've learned that we could apply to this much bigger area of the HAIs, and then we'll have Mary close us, and then we'll let you all go. But I want to thank all of you for a fabulous job, and we'll have videos and linkages and these resources up on the page, and also an update in the deck with these resources that Arjun has described, so that you can go back and get them. But Arjun, as we think about not wasting the crisis and the bigger issue of HAIs, which you've always been so helpful, directing us on, that issue, and then Mary, please inspire us and close us.
Yeah, absolutely. Just very briefly, we'll reiterate that I think what Ebola is teaching us is that there is a need for truly robust systems, that we have to build healthcare safety, including preventing healthcare-associated infections, onto strong systems of safe care. And we need to do much more to invest in, develop, and promote safe systems of care. Mary?
Fantastic. Mary?
Yeah, thank you so much, Chuck, and thank you everyone who presented today. I think we're a learning community. We can only do this work as a team. Patients and families and the public depend on us staying connected, informed, and as wise as we can be. And thank you for all your advocacy on behalf of the entire the global health community and all of the citizens.
Thank you very much, Mary. We'll ask our speakers just to stay on for a second so we can have a rapid process improvement loop. Godspeed to everyone. We will have a transcript of this full recording, the slides and the updated slides for you within 3 business days. Take care. Have a great day.